refractory seizures in the ICU. That is what we regularly in and out see in our ICUs. Patient may come with the seizures to the ICU or may present seizures in the ICU, leading to the problems. And why it is important topic as a critical care doctor is finding out the cause. Early treating is important to prevent the neuronal damage and prevent the it leads to early recovery of the patient, prevent the mortality of the patients. And just we'll discuss about the yes. Today my topic will be the definitions of the status epilepticus and what are there are 2-3 definitions in the status epilepticus and etiology, pathophysiology, and what are all diagnostic things you have to do. What is the role of EEG and what is the common managements and drugs. And last I have a word about non-convulsive status epilepticus and what is my role in the treating the complications. That's what we are discussing today. And there is a difference between epilepsy and seizure. Epilepsy is a neurological disorder in which a person has 2 or more unprovoked seizures that occur more than 24 hours apart. It's called as epilepsy. A seizure is an excessive surge or altered activity of brain that may cause variety of symptoms. It can cause tonic-clonic symptoms or it may not have tonic-clonic symptoms. It can seizure. Next, why it is called status epilepticus? If the seizure activity is prolonged more than 5 minutes, our patient does not recover the consciousness between 2 or 3 seizures, we will call it as status epilepticus. Or if you have a continuous EEG, a patient having continuous bursts of seizures, even if it is not having any clinical tonic-clonic activity, it is also called as status epilepticus. And why it is important is recognizing risk factors. And management is as important to prevent the neuronal death. And what is refractory? First, refractory is you need to first, we all know that you need to use the first line benzodiazepine. It is usually now we use the lorazepam. After that, you will use the first line anti-epileptic that. After that, also, if the patient is having continuous seizure activity, then it is called as refractory status epilepticus. And if the patient after refractory status epilepticus, you will use the one anesthetic agent to control the seizures or burst suppression of the EEG. After 24 hours of the using of one benzodiazepine, one anti-epileptic or 2 anti-epileptics, one anesthetic drug, and stopping of the anesthetic drug after 24 hours to see further whether the brain seizure activity decreased or not. The patient still again got the seizures, then it is called super refractory status epilepticus or malignant status epilepticus. And next is the acute repetitive seizures, where the patient can have more or 3 episodes of seizure within 24 hours activity. The only difference between status and repetitive seizures is patient may regain the consciousness between the repetitive seizures. The incidence of the status epilepticus, it will be around 10 to 40% in the 1 lakh population. Usually it will have a bimodal peak, usually seen in the children and in the elderly population. The conversion of the refractory to the super refractory status epilepticus will be higher. In the next few slides, I will discuss about the why it is higher of the pathophysiology of status epilepticus. It will be around more than 30 to 40%. And there are around 50% of the patients, you will see the first time they present with the seizure, they will come to our ICU, they will have a refractory status epilepticus. It is called new onset of refractory status epilepticus. These patients usually have the autoimmune pathologies and some other, you don't find out the regular trauma pathology. They will have autoimmune pathology, some other like encephalomyelitis things. And the mortality, definitely, if you're not intervening at correct time and right drug, definitely they will have a high mortality. and neurocognitive sequelae and status epilepticus also very high. And International League Against Epilepsy, they have given some definitions by the seizures type and epilepsy types and epilepsy term. It will be focal type or generalized type. If it can be focal with motor and focal with non-motor, or generalized with motor, or generalized non-motor, or it can be, you don't know that what is the exact reason, or it they will have some tonic-clonic movements and it will subside, and they will have some behavioral changes and they will immediately become normal. You don't know exact cause, exactly what exact cause of the seizure. It is called unknown onset or idiopathic onset. And this is epilepsy classification. And coming to the classification of the status epilepticus, it can be prominent convulsive one, it can be generalized at focal or focal motor, and it is tonic one or hyperkinetic one, or without prominent motor syndrome. That you need to diagnose this with non-convulsive status epilepticus with coma or without coma. Patient, you can see patient will be talking with you and suddenly become unresponsive. Again, he will become having abnormal movements in the heart, and he will be complaining in the ICU with I'm having hallucinations, I'm having autonomic hallucination, I'm having some abnormal sounds hearing continuously, and patients suddenly becoming mutic, becoming mutism. These type of fields are seen in the non-convulsive status epilepticus. And sometimes they will have autonomic disturbances in the status epilepticus also. And next, what are the common causes? What regularly you will see in the status epilepticus in community will be the subtherapeutic anti-seizure medication. Those are already diagnosed as seizures, not taking proper drugs, or not taking the missing the pill is the main reason having the seizures. Once the seizure occurs, it continuously have seizures and it will go into the seizure to the status epilepticus. Another will be the alcohol withdrawal, and next will be the drug toxicity and infection, trauma, or any tumor. And you all know another thing we should always never forget in the ICU, it can cause the drugs also the major culprit. But the common drugs what we see regularly will be the fluoroquinolones and carbapenems and some beta lactams. Carbapenems, it is imipenem elastin, has the highest incidence of having the seizure than the other carbapenems, and fluoroquinolones definitely have high risk, and cefepime also having the high risk. And next, you all know that definitely if patient is having any metabolic disturbances or any infections and many vascular events in the brain, they can present with the seizures. That's what just continuation of that. If patient is having trauma, acute one like trauma, intoxication, and infection with tropical fevers, or patient with progressive brain tumors or progressive encephalomyelitis and dementias can have a seizure tendencies. And they found out is in the developing countries, what they found out, it's not the low at anti-epileptic drug levels, it is the infection is they found out in the highest cause of the having status epilepticus in the developing and low socio-economic countries. In children, it is the infection. In young old people, it may be the metabolic, or it can the stroke might be the cause of the having status epilepticus. And coming to the pathophysiology, the seizure can be triggered by so many events. It can be the tumor, drug, toxin, whatever it may be. But what happens once it is triggered, it causes alteration of the internal milieu of the neuron, causing the release of some excitatory and inhibitory neurotransmitter. If inhibitory neurotransmitter in the brain will be the GABAergic. Usually, once the seizure comes, GABA will be activated, it suppresses the seizure. If the seizure continuously happening, it causes GABA apoptosis. So your GABA receptors will be down. Yeah, the next excited neurotransmitter like glutamate levels, substance P, neuropeptide Y, and NMDA receptors and AMPA receptors will be upregulated. This causing the continuous seizure activity. Once your cell is causing damage, it will release so many free radicals from the cells and nitric oxide from the cells, causing the further damage of the adjacent cells. So that is why if you are using one agent in the status set triggers may fail, you need to use other agent which is having different action. If you are using the benzodiazepine, it is mostly GABAergic. And if you are using Levipil, it acts on synaptic vesicles. There is a specific receptor of synaptic vesicles, it acts on synaptic vesicles. And next anti-epileptic should be used is something like phenytoin, valproate. It mostly acts on the lacosamine, mostly acts on the sodium channels. The chance of failing if the similar action anti-epileptic will be more. So that's why the next generation of and just next you need to use the anesthetics. The like midazolam, highest dose of midazolam, and next you need to use propofol, which is having both GABAergic and NMDA receptor activity, or ketamine, like which is having complete NMDA antagonist, now becoming popular in the status epilepticus. Another new drugs that acts on like a parama panel, which acts on the glutamate receptors. Now it is came into the market to prevent the suppress the other excitatory neurotransmitters because of the continuous seizure activity causing the loss of GABAergic neurons. This is what happens in type A respiratory, the normal cell having the highest GABAergic one. Whenever the patient is having continuous seizures, that is the upregulation of NMDA receptors and loss of GABAergic. This is what happens in the refractory status epilepticus, failure of anti-epileptic drugs. That's why our role is to find out the status epilepticus early, treat early with good drugs with different actions, and if it's not containing, sedate and give anesthetic infusion, calm the brain. Otherwise, you will get more damage and have a more neurological sequelae. This is what I already discussed. That is the main three channels we need to be always remember is the AMPA receptors and NMDA receptor and metabotropic channels. And these, because activation will cause the damage of the cells, release of free calcium to toxic levels, causing further excitation. This is already I have discussed these things. And that's why the failure of the anticonvulsants, first failure of the drug sequential, it may fail. First antibiotic, it may be successful. Second antiepileptic, the success will come down drastically because of upregulation of other excitatory neurotransmitters and downregulation of GABAergic ones. And how we can find out and what is the role, how you can see that patient is continuously seizing. The patient may not show the tonic-clonic activity. Patient comes with have the GTCS activity. He may not gain the consciousness in between. Patient will be calm, having tachypnea, tachycardia. Then patient is calm and composed, but calm. He's not having seizure, but the electrical activity still continuously happening in the brain. Initial stopping of the seizures. That's why it is important to have a immediate EEG after the status epilepticus to see for the spikes, to see for the where is the focus, because even after suppression of the tonic-clonic activity, the continuous electrophysiological activity is continuously happening. Okay. And if you are using any anesthetic drug or any IED drug, our target is to calm the brain. That is, burst suppression is our target. Then only you will achieve the target. And now is the role of quantitative EEG, that is diagnosis of neuropsychiatric disorders, that is epilepsy, in the ICU. And not having this equipment, this is what is now is coming. I think next 4 to 5 years, definitely we will all be having this equipment. This we will connect this monitor. We will connect the electrodes on the brain. Will connect to the monitor. It will gives the activity of the brain with the amplitudes. It will show this the activity in the lobe. This lobe will be the higher, and you can adjust the dose of anesthetic and sedative with this. I think Nihan Koden, they are launched this one, what I remember. Still, I never seen this monitor, but one workshop when I seen, they are showing in Madanta, this is the continuous EEG monitor. I think next 4 2 years, we will definitely have this monitor. And routinely now we are asking the EEG technician to keep the check for the EEG. But whenever if your patient suspecting status epilepticus, we need to ask the EEG technician to have a 1 hour or 2 hours of EEG, because the picking up of the spikes in the EEG will be good in the initial half an hour to 1 hour. Intermittently also you can see in the EEG, so that you can find the pathology. Because there are altered sensorium in the ICU, there are n number of causes. It can be of drugs, it can be of the primary pathology itself, it can be of some other encephalopathy or hepatic encephalopathy, uremic encephalopathy might also the cause. So picking up the status epilepticus is our main goal. This is this EEG patterns, that is whether it is generalized or lateralized. This is this is not much relevant to us, but definitely we need to discuss with our neurophysician to have what are the plans we need to go. Patient is having this type of discharge. It is focal, you need to what drugs you need to use, these things. And what we have to do as a critical care physician is, initially the patient came with status epilepticus, definitely he will have tachypnea, tachycardia, increased cerebral blood flow, and he needs more glucose supply. So immediately comes, we will check the glucose. If he has hypoglycemia, we need to give glucose along with thiamine. And some patients with poor cardiac reserve, they will have a surge of catecholamines, may leads to the cardiac failure, may leads to the neurogenic pulmonary edema, may leads to arrhythmias, may leads to sudden cardiac death. And if continuously having seizures, they will have aspiration pneumonia also. And if you have a continuous metabolic activity in the muscle, leads to lactic acidosis, respiratory acidosis, and rhabdomyolysis, causing the kidney damage, respiratory metabolic acidosis, and leads to the release of potassium outside, causing arrhythmias in the heart. And if the further acidosis may worse the seizures, you have a further seizure episodes. So our goal is to find out early and terminate. And if you're continuously seizing more than 30 minutes, you will have so many metabolic abnormalities, and along with the organ damage. Main organ will be the heart, lungs, and your brain and your kidney will be damaged, and with hyperkalemia and all those things. So those treated within 1 hour, they have a Kaplan-Meier curve showed they have a better survival, almost near to the 100%. You are treated more after 1 hour, they showed decline in the survival. They have very bad neurological sequelae. What are the poor outcomes in the status epilepticus? It is the duration of seizure, patient sensorimetric presentation. If it is presented with poor sensor, they will definitely have a poor outcome. And what is the underlying cause, also important. And old age definitely have a poor outcomes because of poor neurological reserve. And patient with symptomatic SC and young patient, and drug is the, so if they miss the anti-epileptic pill, then if they miss the anti-epileptic pill, then they have a better prognosis. And what is our goals of treatment in the status epilepticus? First is to find out, terminate, prevent recurrence, and managing the precipitating cause, and manage the complications. And the approach to any status epileptic patient, it comes to the ER and ICU. First, we will check our goal is to stabilize the ABC. obtain IV access, and check for the ABG. You will get immediate ABG. You will find the what are the basic abnormalities in the AEG, sorry, ABG, and you can correct those things and send for all the metabolic parameters. If patient on anti-epileptic drugs, you can check, you can send for the phenytoin valproate levels to see whether patient is maintaining good levels or not. And it is always preferable to have a continuous EEG monitoring, but it is it is practically difficult now. It may be in the near future we may get all those equipment and gadgets, and definitely it's always CT is the best one. You can do it quickly, and if patient with new onset, you can go with CT. New onset of seizures, go for the CT is the best because you can do it very quickly. But MR is the best one to find out the exact pathology of the epilepsy. And next, if after ruling out there is no rise in ICP, you can go for lumbar puncture to check for the infections, any other autoimmune encephalitis panels and meningoencephalitis panel, check to treat whether it is treatable or not. And toxicology panels are so many important because so many toxins are the status epilepticus. And definitely we'll order one EEG also. And what is our after coming to the had done the just you have sent for the labs. Next, initial 5-10 minutes, our goal is to rapidly give the first line anti-epileptic. There is a benzodiazepine. Second anti-epileptic, it comes to the Levipil, valproate, phenytoin, or lacosamide, or phenobarbital. And next, if the patient is not subsiding within 30 to 6 minutes, continuously having seizures, protect airway, intubate, give IV anesthetic infusion like propofol, midazolam, ketamine, or thiopentone. And if it is continuously having the more than 24 hours, you need to find out other modalities of treatments, what might be the pathology. This is the just algorithm of the chart. This is given in our Think textbook. I found it is very useful. Patient with, it could be generalized clonic-tonic seizures, that is generalized convulsive status epilepticus or non-convulsive status epilepticus. It is almost the treatment algorithm will be same. You may not in generalize a tonic-clonic activity, the metabolic disturbances and kidney injury, organ injury may be more, but neurological injury may be high in the non-convulsive status epilepticus. So the treatment will be the same. Only thing we need to find out the NCSC by the EEG only. First phase with always with the stabilization phase, secure ABC. If airway protected, then your half the job is done. And circulation, maintain the blood pressure, maintain the saturation, that is the main one, and maintain the metabolic, there is glucose supply to the brain. And first line always the benzodiazepines, and there is a lorazepam found to be the superior than the phenytoin and valproate, and with the least side effects, least airway disturbances. So lorazepam is the preferred choice. Now American FDA, American people given approval for the clonazepam also, but now at present in India, no clonazepam IV is available. Lorazepam is the best, that is IV. If you are unable to secure the IV access, if you want to give the IM, go with the midazolam. Midazolam, if patient is an adult, give for 10 mg IM. There is more than 0.2 mg per kg body weight. If you want in pediatric population, doing those three things difficult, go for rectal diazepam. This is also good thing. This is the first line therapy. Next, we need to give definitive anti-epileptic therapy to decrease the further recurrence of seizure. This is our main goal. These are anti-epileptic drugs routinely we use in the status epilepticus. It can be First, we are everyone using a Levy pill. There is a levetiracetam. Because of better side effect profile, you can use it in every organ damage, and there is no cardiac problem. But the only thing in the patient with renal problem, you need to have a dose adjustment. Next come, if you have given Levy pill, the patient is having, you have a continuous seizure, then now we are regularly using the lacosamide. It has usually now it has a approval for the only focal onset of seizures, but still we can use it now for the status epilepticus also. And otherwise you can use the second, when patient, if the again patient having seizures, then you can use the second time of lorazepam or midazolam also. If the seizure stops, it's okay. If the seizure still persists, you need to go for the anesthetic infusion. The first line always the midazolam. Because of his better profile, the only problem with the midazolam will be the prolonged action, high volume of distribution, and definitely have a longer sedation when you are patient. Definitely when you are keeping midazolam infusion in higher doses like 0.2 mg to 1 mg or 2 mg per kg body weight, definitely patient need to be intubated. You may find trouble when weaning from the ventilator, definitely, but this is the first line when you have a patient is having seizures continuously. Even with the midazolam also, if patient is having seizures, then our drug will be the propofol, because it has GABAergic action and NMD action also, and faster acting, less half-life. The only problem will continuous prolonged infusion may cause the risk, that is propofol related infusion syndrome. And next, previously they described to use for the thiopentin, that is phenobarbital, there's 5 mg loading followed by 0.5 to 5 mg per kg per hour continuous intravenous infusion. But now the guidelines has little bit given to the edge for the ketamine, because it has an NMDA receptor action and less requirement of the inotropes, because propofol and midazolam definitely has a decrease the blood pressure. So ketamine has less inotropic support compared to the phenobarbital, and the suppression of burst suppression also found early in the ketamine. Initially, they found that ketamine increased the every pressure, but ketamine with midazolam or ketamine with propofol, what they found out having, there is no rise in the ICP. The burst suppression they achieved faster also. And if the patient is seizure stops, how you found it is like always it's the EEG. Patient have a burst suppression. After that burst suppression, we'll start slowly weaning off one and first we will stop the propofol or thiopentin, ketamine, next midazolam, decrease the dose. Again, we see the burst suppression if achieved or not. Then if the patient is again got the seizure activity, you need to continue the same protocol. Otherwise, you can taper off each drug sequentially, and in between finding out cause, do a MRA, do a LP. If you found that is an autoimmune encephalitis or some infection or tumor, go for surgery. If trauma, decrease the ICP pressures, and take if raised ICP might be the cause, go for the measures to decrease the ICP. These are all things you need to do in between this time, finding out the cause. And if patient is continuously having seizures in spite of all these things, then you need to find alternate therapies like ketogenic diet or neurosurgical resection like seizure focus. There are I never seen that surgery done, but one time I've seen there's a corpus callosum. They have a extra fibers between the corpus callosum in children. What they used to do, they used to ablate the extra fibers in between the corpus callosum. And that's already discussed the steroids, the plasmapheresis, IVSG, if the patient is having any autoimmune pathology. Or next is the deep brain stimulation. And if it is it is sometimes ECT, that is ultraconvulsive therapy, may also be useful. And transcranial magnetic stimulation, I have never done it. And ECT also I have never done it. But we use the steroids, those I think now every neurologist will use status epileptic patient even before getting diagnosed. They will use the high dose of steroids unless until the no pathology. For they are suspecting this autoimmune only. And next, we can go for the complete hypothermia. That is what we do in the post-cardiac arrest patient also to decrease the whole activity of the brain. This is just this is the what I discussed previously. This is one slide. This is the drugs. The dosage of the drugs. There is lorazepam. There is a 0.1 mg IV up to 4 mg. May repeat once after 5 to 10 minutes also. Midazolam 10 mg IM. The body weight is more than 40 kg. 5 mg IM. Your body weight is 13 to 40 kg. Diazepam. You can go up to 0.15 to 0.2 mg per kg body weight, up to 10 mg per dose. Now we are not using diazepam, but we can use pediatric population for rectal diazepam. And anti-seizure medication, we all know previously we were using phenytoin. Now we are not using much phenytoin because of their side effect profile and their cardiac events, and they can cause the hyperthermia. Next, valproic is 40 mg is the loading dose up to 3 grams you can give. That only concern the patient is having any liver related issue. Be careful before giving the valproate. And another problem with the valproate is it can cause the rise in the ammonia, and it is one of the cytochrome CYP inducer. So it has a drug interactions also with the acetram and all those things. So far now, Levipil is the safest drug. Another drug, it is also FDA approved now. It is the Brevicitram. Now, I think IV is available in Vizag also. We are using regularly. I am not using, but I think so many neurologists in the Vizag are using. That is a Brevicitram. The dose exactly, I think they are giving 200 mg start followed by the 100 mg BD as for status epilepticus, I think. And phenobarbital, it is the previously they used to use. Now I think they are not using much of phenobarbital. Now we are using the patient is having, you are using almost phenobarbital, valproate, phenytoin, Lacos would have a similar GABAergic action, similar type of, it acts on similar channels. So if patient is not responding to the phenytoin, valproate, and Lacos move, better to go for the your anesthetic infusion only. Next, this is the already discussed midazolam profile and pentobarbital. And our role to treat the complications is mainly patient with convulsive status epilepticus. Initially, he may present with tachycardia, hypertension. And once the muscle activity high, you may see the rhabdomyolysis, and they will have a rise of CPK. How we find this rise of CPK? This rhabdomyolysis causes kidney damage, and they will have a hyperthermia. Now, I think it is not FDA approved. What you're using brain related rise in temperature. We are regularly using bromocriptine to decrease the central related fever. We are finding little bit good results only, but it is not yet approved. I think I think in next 2 to 3 years, if everyone routinely use, you will get the what is the side effect profile of the bromocriptine also. Regularly, we are using the bromocriptine, the central cause of the fever, but we are getting good results only. So far, so good. Around 60 to 70% we achieved success only. Not 100%, I can say, but it is a little amount of we have used only 40 to 50 patients only. And patient with it can cause respiratory complication. It is the neurogenic pulmonary edema because surge of catecholamines and definitely continuous activity of brain increase the cerebral blood flow causing cerebral edema. And actually I am a known epilepsy patient, so I know that if increased blood pressure, increased any blood flow to the brain, it can cause the headache. Definitely whenever had a seizure like activity, definitely I can find out after around less 6 hours I will have a headache. Definitely they will rise the ICP because it was the cerebral edema only. So our main goal is to neuromonitoring, and you need to decrease the ICP also. This is also our goal, not not only to suppress the seizure, you need to decrease the ICP, because raised ICP, it is a closed space, further damage the members. This is the similar thing what I discussed already. And this is one thing. Whenever they used EEG, burst suppression is not only the indication what they say, what they said in 2017 one paper, that burst suppression you had achieved means it is not only the indication of status epilepticus, but the patient of it is only indication of your drug activity control the brain seizure activity. If it is again coming back, means you are still not addressing the primary pathology. Your patient still at risk of the refractory status epilepticus. And there is a predictor scoring. Those are having a mortality prediction. Those are having presented with consciousness, definitely have a good outcome. And those are having NCS, non-convulsive status epilepticus, have a poor outcome than a convulsion, because the finding out convulsion is easier than the non-convulsive. Always old age have poor prognosis, and new onset status epilepticus has a poor prognosis than the patient with history of previous seizures. This already I discussed about the drugs. And next, just I want to add a word about role of muscle relaxant. Once actually, recently when I am going one patient with status epilepticus, one of our resident told that, sir, we will give a relaxant to decrease the status epilepticus. Then I found that what you are achieving by relaxant, we can only achieving is the only decrease the muscle activity of the seizure, but you are not stopping the seizures. And when you are not monitoring the brain activity with continuous EEG or like quantitative EEG, if you are giving relaxant, you are losing the major monitoring of it, is the if you are focal activity of seizure or motor tonic clonic activity of the seizure. So before giving the relaxant in the status patient, you need to think if it definitely it is causing much of metabolic abnormality like hyperkalemia, causing temperature and continuously biting of the tube, causing difficulty in ventilation, hyperthermia, then you can use it, but it should be at the caution. You need to have a sequential burst suppressing the activity of IV anesthetic also before you are using the muscle relaxants in the status epileptic patient. Just already discussed the hypothermia. At hypothermia you can use it, but definitely hypothermia has its own disadvantage also. Just there are only two words about this drug I discussed in the param panel. I think so many people now, neurologists are using now param panel patient with. This is now we are using. This is not that came in the guidelines, but is not for the NCS. It is for the tonic clonic seizures activity of status epilepticus. It acts on the glutamate receptor. It is a different receptor. What we will use mainly antibiotics, GABAergic and sodium channel inhibitors. Next will be the NMDA, ketamine. Next, this is the glutamate receptor antagonist. So it is other receptor. So that's why they are using in the last line of treatment. If you are not achieving the burst suppression, that it is the trade name as a 5-compa. You can go up to 32 mg per day in the status epileptic patient. It is orally available. That is the only disadvantage. And this is the recent article that published in the Neurology Journal. Ketamine to treat super-refractory status epilepticus. It is already discussed as a malignant one. Ketamine treatment was associated with decrease in the seizure burden in patient with super-refractory status epilepticus. High dose of ketamine infusions. Previously, we thought it is increase the ICP, but definitely there is no increase in the ICP. But one good thing is requirement of vasopressor definitely will be low. If you are using high dose of midazolam at around 50 mg per hour or 100 mg per hour, at propofol at almost around 200, 300 mg per hour, definitely will have a low blood pressure only. You need to use NORAID or NORAID support along with that. You because of the tendency of it causing hypotension. But along with ketamine, what they found, the requirement of vasopressor will be less. This is one thing I found is a good article. One of my another thing I read about the thiopentan coma. I have done around around in my clinical last 4 years in the critical care practice. I have done around 4 to 5 patients of thiopentan complete coma who are refractory to the propofol, midazolam, and ketamine also they found who had done thiopentan infusion. What I found out is definitely it has a severe hypotension, and previously there are 2 papers published. It can cause the immune paralysis and the outcomes will be poor, and the half-life will be also very much prolonged. That's why now we are using propofol, ketamine, midazolam than the thiopentan coma or barbiturate coma. We need to use barbiturate at the last resort only. And this is the role of ketogenic diet. I'm not having much of knowledge, but when in one young patient we have used ketogenic diet, but the parallelly we are using thiopentan coma also, but I don't have any personal experience. And the autoimmunity already I discussed. And only one word about non-convulsive status septicus. You need to find out this one patient with altered sensory in ICU, with bizarre behavior and abnormal movements. They may have NCSC. Do a EEG. If you find it is a NCSC, you know, treat as similar to the status epilepticus only. There are criteria like Salzburg criteria. I'm not much going into the EEG thing. I am not also much aware of EEG, but I know only that there is a spikes of more than 2.5 to 3 H. I can find it is a seizure-like activity. There are 3 spikes. It is seizure-like. If it is more, if you see more darkness, it is a artifact. That much only I know about also EEG. I need to train in EEG reading also. So I am not much teaching you also, and I don't know how can I teach others. Sorry for that. Next, there's a criteria like there are 2 scores. One is HELP 2B score and a Salzburg criteria for the finding of the NCSC in the ICU patient. This is patient with having more than 2.5 H per seconds, and this is having, if the patient is having 1 lobe spikes, they can so this lobe might be the cause of status epilepticus with altered sensorium, and it is suppressing by giving IV benzodiazepine or IV anti-epileptic. You can say that patient is having NCSC. That much only I am telling for it. And the same algorithm for the treatment of status epilepticus. This is, I think already I discussed. I am lorazepam more effective, IV lorazepam more effective than phenytoin stopping seizures, at least 10 minutes. This is a level 1 evidence. And thanks for the patient listening. Sir.
Thank you, Surendra. Very nice presentation. Explained everything, all the complications and the medication, pathophysiology, and refractory seizures. We had one patient recently, 2 weeks back. Patient is a carcinoma mandible. He underwent asteroidectomy. After 2 days, patient in the ward, he developed seizures, and they started anti-epileptic drugs and shifted to Pinnacle. Then patient is having a refractory seizures. Started all the medication, refractory MRI done. MRI is normal. LP also done. There's no malignant cells in the CSF. But patient is throwing refractory seizures. As you said, we have given high doses also. Even midazolam gone up to 50 milligrams per hour infusion.
Sir.
Ketamine infusion. And all the drugs what you have mentioned in your chart. But patient is throwing daily, at least 5 to 10 times seizure activity in spite of these drugs. So patient pupils are dilated finally, and this is almost brain dead. No cough reflex, no brainstem reflex. So patient taken LAMA. I didn't understand why after all these explained medication
Sir,
so far.
that's what, sir. What my experience, what I read, what I seen in actually I seen around 15 to 20 cases of status epilepticus. Definitely 5 cases are died because of so many complications, and some are gone LAMA, some are gone and around. I didn't follow it up. That, but you are saying malignancy, they might be having the paraneoplastic one. The paraneoplastic, they might work better with the steroids. If you find out,
Steroids given.
Steroids, you can go with the plasmapheresis also. These patients may work. It may work. It may work.
Yeah. IVIG given and steroids started initially, and later IVIG also started. No response.
IVIG may take time, sir. Plasmapheresis work good. What I feel, because it removes immediately the antibodies.
LAMA next IVIG they went on LAMA. They didn't stay. But the thing is, by the time patient developed, people's dilated and brainstem reflex are gone.
It might be, sir, మనం ఫైండ్ అవుట్. అందుకనే అంత ఏంటంటే టైమ్ ఈజ్ బ్రెయిన్ అని బేసిక్ స్టాటస్ అంటే నేను చాలా రోజుల క్రితం చాలా మళ్ళా రివిజన్ చేసినప్పుడు నాకు ఏంటంటే if you are lating by 30 minutes, you are losing all the inhibitory neurotransmitters. You are only having the excitatory neurotransmitters and damaged neurons. Your brain drugs won't work there. That's what they are saying. The receptors are gone.
Okay.
And you need to address the primary pathology. That is our main goal. This is only symptomatic treatment. What I have said, primary pathology is our main goal, sir.
But to find out the primary pathology also sometimes difficult. We'll do CSF analysis, MRI, EEG, whatever it is available, we will do. Autoimmune profile, okay, encephalitis panel,
but not available in other places.
Everything.
Not available in all the places.
Yeah. Yes, sir.
సార్ మీరు అన్నట్టు కావాలంటే ఇది ట్రై చేయొచ్చు సార్. హైపోథెర్మియా ఏమో తెలియదు, ఆయన హైపోథెర్మియా నేను ట్రై చేయలేదు, కానీ థయోపెంటోన్ కామా మాత్రం నేను ట్రై చేశాను సార్. ఆ 5 పేషెంట్స్ వర్క్డ్ వెల్. బట్ ఓన్లీ ప్రాబ్లం ఏంటంటే దాంట్లో 3 చచ్చిపోయారు, 2 బతికారు. బట్ ప్యూర్ న్యూరలాజికల్ సీక్వెలాలు మనం తర్వాత నేను నారాయణలో పనిచేసినప్పుడు చూశాను. తర్వాత నేను ఎప్పుడు మళ్ళీ ఫాలో అవ్వలేదు, కానీ 3 నెలలు మాత్రం బతికి ఉన్నారు. అంటే హీ హాజ్ ఎ బెడ్ రిడన్ స్టేటస్. హీ కేమ్ బ్యాక్ ఒకసారి విజిట్కి వచ్చాడు ఐసీయూకి, బట్ డెఫినెట్లీ బెడ్ రిడన్ మీద ఉన్నాడు. థయోపెంటోన్ మాత్రం వర్క్ చేస్తుంది సార్ డెఫినెట్ గా. మొత్తాన్ని బ్రెయిన్ యాక్టివిటీ అంతా తగ్గించేస్తుంది అంతే. వాట్ ఐ ఫీల్. కెటమైన్ అయితే మేము రెగ్యులర్ గా వాడుతున్నాం సార్.
కెటమైన్
ఈ మధ్యన వాడుతున్నాం సార్. అంటే గైడ్ లైన్స్ ఇంకా రాలేదు. ఇప్పుడు నేను పెట్టిన గైడ్ అంటే ఇప్పుడు కొత్త థింక్ లో ఇచ్చాడు కానీ సార్, మీకు జస్ట్ 2 years బ్యాక్ ఏ గైడ్ లైన్ లేదు. ఈ మధ్యన వచ్చింది కెటమైన్ అంతా.
గైడ్ లైన్స్ పొందుతాము. కెటమైన్ ఎప్పుడుందో ఉంది. ద గైడ్ లైన్స్ వర్ ప్రీవియస్, నాట్ రీసెంట్.
2015 లో లేదు, మన 22లో లేదు.
ఎందుకంటే
లెవిపిల్ కూడా లేదు.
బ్రెవిపిల్ లేదు గైడ్ లైన్స్ లో.
బ్రెవిపిల్ we are using 200 mg IVPD.
ఇప్పుడు చూడండి, అప్పుడు హెపటిక్ క్యాన్సర్ వల్ల డ్రగ్ ఆఫ్ చేసి ఫెనటైన్ అన్నారు. ఇప్పుడు హెపటిక్ క్యాన్సర్ వల్ల ఫెనటైన్ వాడద్దు అంటున్నాడు. ఎందుకంటే దట్స్ హౌ సైడ్ ఎఫెక్ట్ ప్రొఫైల్ మేబీ టేక్స్ టైం. బట్ ఇప్పుడంటే లెవిపిల్ ఇస్ ద సేఫెస్ట్.
నాట్ యూజింగ్ ఎప్సోలిన్ ఆల్సో.
yes sir. సార్ ఓన్లీ థింగ్ ఏంటంటే సిమిలర్ యాక్షన్ ఉన్న డ్రగ్స్ వాడద్దు అంటున్నాడు. స్టాటిస్టిక్స్ ఎంత అంటే చెప్పగలను సార్. సేమ్ యాక్షన్ ఉండి వాడదు, డిఫరెంట్ యాక్షన్ వాడమంటున్నాడు. అందుకనే ప్యానల్ అని కొత్తగా వాడుతున్నారు. మీరు తెలిసి మీ సుమేధ వాడుతూనే ఉంటాడు సార్ నాకు తెలిసి. సుమేధ వాడుతుంది.
everything is okay.
నేను ఫైవ్
This-
కాంపా మీద అంటే పారాంపాల మీద పాజిటివ్ స్టడీ ఉంది సార్. నేను మొన్న అంటే మేము ఒక 4-5 కేసులు వాడాము, బట్ ఐ మీన్ ఫైండ్ ఎనీ గుడ్ రెస్పాన్స్ కాదు. కానీ సీజర్ అయితే తగ్గి ఉండొచ్చు, ఈజీగా బర్స్, కానీ మనం కంటిన్యూస్ ఈజీ చేయం కదా సార్, అది కూడా పెద్ద ఇదే కదా ప్రాబ్లం కదా మనకి.
Hello.
Surendra. Hello,
Sir.
Surendra.
Hello, sir. Good morning, sir.
Transcranial,
Surendra, I'm Dr.
Cheppandi.
Ganesh.
చెప్పు అనురాధా.
వెయిట్ గణేష్ చెప్పు.
I went to do tracheostomy. We have one case in our ICU,
Oh,
12-year
okay, sir.
male patient with meningoencephalitis. He was in our ICU 3 months back. He received IVAG. He was discharged home post tracheostomy prior, and he discontinued medication. And next time he came with status epilepticus. Again, he's having almost for 7 days. He's on ventilator support, and now also is having sometimes he's having seizures. So whether to wait to until the seizures will subside, we have to wait, or we can go for tracheostomy. So I'm asking when to do tracheostomy. They are
చాలా సింపుల్ క్వశ్చన్, చాలా సింపుల్ గా నా ఆన్సర్ చెప్తాను. నాకు తెలిసింది చెప్తాను, గైడ్ లైన్స్ ఏం గురించి చెప్తాను. Any your expected neurological outcome is poor and your expected next 7 days your neurological status is poor, go for tracheostomy because of 2 things. What's your institute lo ni nursing care ala undi, tube care ala undi. If you are doubt, go for tracheostomy. That's it, your individual practice. But if you are suspecting this acute cause, you may see recovery within 24 to 48 hours. Don't go for tracheostomy. That's what my personal experience is. It depends on institutionalized and personalized, depends upon institute also. As per guidelines, poor node patient with low GCS and brain injury, the guidelines is early tracheostomy has the good rehabilitation. But patient with other complications, other things, if you are going pneumonia for early tracheostomy, I may not recommend for early tracheostomy for pneumonia. That's what I feel. If you are suspecting patient with a previous status epilepticus with all of the complications, you are not expecting recovery in the next 7 days, better to go for tracheostomy. Where you are working also more important. I think you know better than me.
Thank you.
అనురాధా.
Yes, sir. Thank you, Surendra,
Madam.
for nice class. So my question is, if post CPR and hypoxic seizures continuously not reducing with the drugs, how to treat?
Madam, same actually that is anoxic status epilepticus. Always what the recommendation is, valproate has best thing but I didn't read the hypoxia. Valproate has a best than the all other things, but still you are using Levipil, Levipil, valproate. Best to go for is the hypothermia. Always hypothermia decreases the brain activity. That's what I may experience. That's what I think so. But definitely you have to go but patient with post CPR, if you're going propofol infusion and thiopentan coma, have a more cardiorespiratory, you have a more cardiac that is vasopressor requirement that may cause further harm to the system actually. So better to go for hypothermia with you can go for you can go for the anti-epileptic valproate and Levipil. It may decrease the brain activity.
Okay, thank you.
Sir, good morning. What is the role of frisium in pediatric patients?
Frisium and sir, sorry, actually, and chadianta chala frisium ante is sir ide diazepam.
Clonazepam.
Clonazepam. Sir, clonazepam. Sir, ippudaithe at present American has a given, you can use the first line therapy IV clonazepam. They have given guidelines to use it, but it is not available in India yet. You can use the clonazepam, sir. Still, it is the first line therapy. But in pediatric stages, you are giving syrup if patient is having intermittent, children having intermittent, you can give syrup, no issues. But status epilepticus, you cannot give syrup, no, sir. You have to give IM or rectal or IV injection. Clonazepam is grade 1 evidence. They have given guidelines recently. I can post that. I didn't update it in this one. They have given clonazepam, lorazepam.
Sir, if the patient is not having any comorbidities, for
Sir.
GTCS, what is the gold standard? It is Levipil or Eptoin?
లెవిపిల్ సార్ ఇప్పుడు అంతా ఎప్టాయిన్ వాడట్లేదు సార్, ఎందుకంటే రెండు పొంది మన ఎప్టాయిన్ కొన్న ప్రాబ్లమ్స్ ఏంటంటే ఫస్ట్ పాయింట్ ఏంటి సార్, అడ్మినిస్ట్రేషన్ చేసే రూట్ చాలా బాగుండాలి. ఇంకోటి టైమింగ్ చాలా ఇంపార్టెంట్. టైమింగ్ ఇఫ్ ఆర్ యూజింగ్ ఎప్టాయిన్ మీరు 50 mg కన్నా 50 mg per minute లోపే మీరు ఇవ్వాలి. ఇంకోటి మినిమం 20 to 25 minutes ఇవ్వాలి ఇన్ఫ్యూషన్. ఫాస్ఫెనటైన్ ఇస్ బెటర్ దాన్ ఎప్టాయిన్, but extravasation of phenytoin out of the vein has more problems. It can cause the thrombophlebitis, it can cause the necrosis of the hand also. So Levipil ఏంటంటే ఇంకోటి phenytoin ఇంకో ప్రాబ్లం అంటే having the sodium channel block, having the more erythemogenic than the other antiepileptic agents. So దాని బదులు మీరు Levipil more safe acting, no sodium channel blockade, acting on synaptic vesicles, and you can give the bolus also, no issues after. కానీ ఫస్ట్ ఎప్పుడు బెంజోడైజెపిన్ ఇవ్వమని చెప్తున్నారు సార్, తర్వాత లెవిపిల్ అని ఇవ్వండి. అంటే ఈ కెన్ గివ్ లెవిపిల్ లోడింగ్ డోస్ ఇన్ రెనల్ ఫెయిల్యూర్ ఆల్సో. లెవిపిల్ తో ఒకే ఒక్క ఆలోచించాలంటే నెక్స్ట్ సబ్సిక్వెంట్ డోస్ ఇచ్చినప్పుడు రెనల్ ఫెయిల్యూర్ ఉంటే లో డోస్ ఇవ్వాలి, ఎందుకంటే మోస్ట్ ఆఫ్ ద డ్రగ్ ఎక్స్క్రీటెడ్ ఇన్ రెనల్.
Thank you, sir. Last question. What is the anti-epileptic choice in pregnancy?
ప్రెగ్నెన్సీ సార్ ఎక్లాంప్షియా అయితే మెగ్నీషియం సల్ఫేట్.
అట్లాగా సార్, ఎక్లాంప్షియా లేదనుకోండి.
ఎక్లాంప్షియా సార్ లెవిపిల్ ఇవ్వచ్చు సార్, ఏమో సార్ లెవిపిల్ యూ కెన్ గివ్ ఇట్ సార్.
ఓకే సార్, ఓకే, థ్యాంక్ యూ.
వాల్ప్రేట్ ఇవ్వకూడదు, వాల్ప్రేట్ అయితే ఇవ్వకూడదు.
So recently we have done one transcranial catheter placement surgery for epilepsy.
Sir.
Mostly it could be the first case. I don't know. Surgeons came from Nimhans and 1 month back we did that. Do you have any experience on that?
నాకు ఒక కేసు అయితే చూసాను సార్. అంటే ఒక కేసు అంటే అప్పుడెప్పుడు ఒక అరౌండ్ 7 years బ్యాక్ ఏంటంటే అప్పుడు ఏంటంటే స్కార్పస్ కెలోజన్ దగ్గర వాళ్ళ మధ్యలో వాళ్ళు కట్ చేస్తారు సార్, అంటే ఓపెన్ చేసి ఆ ఫైబర్స్ ఎక్కువ కంటిన్యూస్ స్టాటస్ రిప్టర్స్ ఉందని. అది ఒక్క కేసు తెలుస్తాను, మిగతా ఏం తెలియదు నాకు, సర్జరికల్ గా నాకు తెలియదు. అంటే నేను మేజర్ న్యూరో సర్జరీ సెంటర్ లో పనిచేయలేదు, బేసిక్ గా ఓన్లీ న్యూరో ఐసీయూలో పనిచేసాము. మేబీ న్యూరో సర్జరీ ఐసీయూ మా స్టాటస్ రిప్టర్స్ లో అయితే నేను చూడలేదు. ఒకసారి సర్జరీ చేసినట్టు మాత్రం చూసాను సార్, దాని తర్వాత ఇన్ఫ్యూషన్ తీసుకొచ్చి వాళ్ళు మా దగ్గర తీసుకొచ్చారు కానీ నాకు తెలుసు అంతే. నేనైతే పనిచేయలేదు సార్ మేజర్ న్యూరో సర్జరీ ఐసీయూ. స్టాటస్ రిప్టర్స్ లో అయితే నేను చూసాను.
Right.
So there are 2-3 points I want to add. 2011 as seen 2011 American Society of Epilepsy guidelines చూస్తే I think they have mentioned about ketamine first thing. Second thing ఏంటంటే Levipil loading ఎప్పుడు we stop at 1 gram. That is a problem. We don't go up to the maximum dose. అంటే most of the times
60 mg కదా,
అది 4.5 gram వరకు ఎవరు వెళ్ళరు. Even in the emergency or ICU, we stop at 1.5 gram దగ్గర stop అయిపోతాం. That is the second point. Third point వచ్చి when you are doing a continuous ECG monitoring, the point is you have to have a camera video recording of the 24 hours. Okay. So ఎందుకంటే you have to differentiate either it is a seizure disorder, seizure activity or something else. అంటే పేషెంట్ ని సక్షన్ చేస్తున్నప్పుడు కూడా you will get some activity. So it should not be confused as a seizure activity. So అంటే మేధాంతాలో నువ్వు చెప్పినప్పుడు
మేధాంతాల వర్క్ షాప్ ఉంది, యాక్చువల్లీ అయ్యింది. నేను అటెండ్ అవ్వలేదు, వెళ్దాం అనుకున్నాను కానీ ఏంటంటే బట్ ఐ సీన్ ఆన్ క్లాస్ వాళ్ళు డెమో వీడియో చూపించారు నేహాన్ కోడిన వాళ్ళు. అది చాలా కాస్ట్. దే ఆర్ కండక్టింగ్ వర్క్ షాప్ ఇన్ ఎవ్రీ ఇయర్లీ మంత్స్. నేను వెళ్ళాలనుకుంటున్నాను, కుదిరితే. ఎగ్జాక్ట్ నాకు పేరు గుర్తులేదు, బట్ నేనైతే లాస్ట్ ఇయర్ వీడియో చూసాను, డెమో వీడియో. నిజంగా ఐ రియల్లీ ఇంప్రెస్డ్.
అంటే
ఏంటి సార్ అది నిహాన్ కోడినోడిది కంటిన్యూస్ ఈజీ మానిటరింగ్ సార్. ఆ డివైస్ అలా పెట్టేస్తారు, హెల్మెట్ లాగా ఉంటది. మనం యూ కెన్ మానిటర్, ఆ సెపరేట్ మానిటర్ పెడతారు సార్. అదే క్వాంటిఫికేషన్ ఈజీ సార్. ఇట్ విల్ గివ్స్ మన దాంట్లో ఒకటంటే మన ఎనస్థెటిక్ డ్రగ్ ఎంత ఇవ్వాలో కూడా చెప్పచ్చు. అంటే బిస్ లాగా కూడా వస్తుంది దాంట్లో, అంటే ఎంత సపరేషన్ ఉంది అది కూడా.
అందులో SSCP అండ్ అవి కూడా వస్తాయా
సరే నేను మరీ డెప్త్ లో నాకు తెలియదు, బట్ నేను చూసాను డెమో వీడియో. అలా వర్క్ షాప్ కండక్ట్ చేశారు, ఇయర్లీ వన్స్ కండక్ట్ చేస్తారు.
సార్ మీ క్వశ్చన్ ఏంటి సార్? మీ క్వశ్చన్ ఏంటి?
డివైస్
హెల్మెట్ పెట్టేది అనస్థిషియా డెప్త్ కోసం అంటున్నారు కదా, అందుకోసమని.
కాదు సార్ ICU లోనే మానిటర్ చేస్తారు. మన
ICU లో కంటిన్యూస్ ఈజీ మానిటరింగ్ ఇస్ కంప్లీట్లీ డిఫరెంట్ సార్.
అదే
దాంట్లో మనం మానిటరింగ్ కూడా చేయొచ్చు కదా సార్. అంటే బ్రెయిన్ యాక్టివిటీ, బిస్ అంటే బ్రెయిన్ యాక్టివిటీ కదా సార్ మానిటర్. అంటే బిస్ మేబీ కంబైన్డ్ అనుకోండి సార్, దాంట్లో మన ఈజీ యాక్టివిటీ కూడా చూడొచ్చు కదా సార్, అనస్టిక్ ఎఫెక్ట్.
అది వేరు చూడండి, ఎందుకంటే నేను సత్యసాయి దాంట్లో చూశాను, అందుకని చెప్తున్నాను
సార్.
Okay, thank you, Surendra.
Sir, thank you.
Nice presentation and explained everything. Thank you all the audience for your active participation.
థ్యాంక్ యూ సార్, థ్యాంక్ యూ ఫర్ గివింగ్ ఆపర్చునిటీ. కుదిరితే ఈజీ వర్క్ షాప్ పెట్టండి సార్, నేర్చుకోవచ్చు.
ఈజీ వర్క్ షాప్ పెడతావా అంటారు సురేంద్ర?
ఈజీ సార్, ECG కంటే ఈజీ, కానీ అంటే కొద్దిగా లాజిక్ ఉండాలి అంతే. చాలా ఈజీ సార్. అంటే నాకున్న నేను తెలిసిన 4 మొక్కల్లోనే సీజర్ ఉందా లేదు తెలిసిపోతా ఉంటుంది. అంటే నాకు తెలిసిన 4 అట్లా చెయ్యొచ్చు, కానీ మనం దాన్ని ట్రైన్ అవ్వాలి.
ఈజీ ఒకటే కాకుండా ఈజీ, ECG అండ్ ABG, జీ లాస్ట్ లో జీ వచ్చేలాగానే. జీ కైసా హై జీ?
సురేంద్ర,
మేడం చెప్పండి.
నైస్ టాపిక్ అండ్ గుడ్ ప్రెజెంటేషన్. క్వశ్చన్ ఏంటంటే, when you have a triggering factor, okay, you have status and you put the patient on so many anti-epileptics, but triggering is dealt with. So tarvata enni rojulu, how long would you continue all these? Oka 3-4 pettestam kada. So how long will we continue and how will we taper off? ఏది ఫస్ట్ తీసేస్తావు, ఎలాగా, ఎన్ని రోజుల తర్వాత?
మేడం అంటే మన ICU లో మనం డీల్ చేసేది మాత్రం ఫస్ట్ ఎప్పుడు IV అనస్టిక్స్ తగ్గించేస్తాం, నెక్స్ట్ బెంజోడైజిన్స్ తగ్గిస్తాం. ఒక్కొక్కటి డోస్ యూజువల్ గా మనం మీరు అన్నట్టు లెవిపిల్ హై డోస్ ఇస్తాం, లాకోసమైడ్ హై డోస్ ఇస్తాం. ఒక్కొక్కటి డోస్ తగ్గించుకుంటూ వస్తాం. పేషెంట్ అగైన్ సిమ్టమాటిక్, యూ నీడ్ టు గివ్. యూజువల్ గా మేడం 2 యాంటీ ఎపిలెప్టిక్స్, ఒక బెంజోడైజిన్ కంపల్సరీ ఉండాలి. 2 types of action of anti-epileptics పెడతారు మేడం. ఇది నాకు తెలిసి యూజువల్ గా పంపిస్తారు. సోడియం ఛానల్ బ్లాకర్ ఒకటి, లెవిపిల్ ఒకటి, అంటే 2 యాక్షన్ ఉండాలి, ఒక బెంజోడైజిపిన్ ఉండాలి. అలా పెట్టి యూజువల్ గా డిశ్చార్జ్ చేస్తారు. అంటే నేను న్యూరోఫిజిషియన్ కాదు, బేసిక్ గా మీరు చెప్పడానికి నాకున్న మినిమం నాలెడ్జ్ తో చెప్పగలంటే లాజిక్ ఏంటంటే, ఇలా పెడితేనే దే కెన్ హ్యావ్ గుడ్ థెరపటిక్ లెవెల్స్. లేదు అంటే మీరు వాల్ప్రేట్ ఫెనటైన్ చెక్ పెడుతున్నారంటే కంపల్సరీ లెవెల్స్ చెక్ చేయాలి ఐడియల్ గా అయితే. లేదంటే మీరు లెవిపిల్, సోడియం ఛానల్ బ్లాకర్, బెంజోడైజిపిన్ అలా పెట్టుకొని వెళ్ళిపోవచ్చు. అంటే లాజికల్ గా ఆ డ్రగ్ ఇంటర్వెల్స్ చూసుకొని అలా పెడితే మేబీ బ్రెయిన్ లో మెయింటైన్ అవుతాయి. బట్ డెఫినెట్లీ మిగతా ఆర్గాన్ ఇంజరీస్ చూసుకొని పెట్టాలి లెవెల్స్, నాకు తెలుసు మేడం. అయితే బేసిక్ గా మనం OPD
nobody will be more experienced or known than you about seizures. Don't worry, you are the best answer, Surendra.
అలాగే కదా సార్, నేను చెప్తున్నాను సార్, జస్ట్ ఐఎమ్ ఎక్స్ప్లెయినింగ్. అంటే ఒక్కటని ఆపేస్తే మనం ఎక్స్ప్లెయిన్ చేయలేం సార్. ఇది ఆపేమంటే వచ్చిందని మనం చెప్పలేము సార్. యూనిట్ టు బి మోర్ కాషన్. ఇలా నాకు అర్థమైన కాన్సెప్ట్ ఇంతే మేడం. మేబీ న్యూరాలజిస్ట్ మేబీ ద బెస్ట్, హీ కెన్ గివ్ ద బెస్ట్ ఆన్సర్. నేను ఓన్లీ స్టాటస్ వరకు అయితే చెప్పగలను, బట్ ఇది అవుట్డోర్ OP ప్రిస్క్రిప్షన్ మేబీ అని నేను చెప్పలేను మేడం.
అంటే మనం ICU నుండి డిశ్చార్జ్ అయ్యేటప్పుడు we see them having so many things, లెవిపిల్, లాకోజమ్, ఎంకరేట్ ఏవేవో ఉంటాయి కదా వీళ్ళకి. సో యా మేబీ న్యూరాలజిస్ట్ యూజ్ చేస్తారా, దెన్ టు స్టార్ట్ 1 by 1 తగ్గిస్తారా, టు కంటిన్యూ ఆన్ లెవిపిల్ ఫర్ లాంగ్ టర్మ్? సో దట్స్ వాట్ ఐ వాస్ సేయింగ్.
మేడం మామూలుగా అయితే గైడ్ లైన్స్ సేస్ వన్స్ యు హావ్ ఎ సీజర్స్ యూ కెనాట్ స్టాప్ మెడికేషన్. వన్ సపరేషన్ వస్తే కంపల్సరీగా 6 months వరకు, 1 year వరకు మాడిఫై చేయకూడదు. 3 years అయితే ఎట్టి పరిస్థితుల్లో ఆర్గానిక్ ఇంజరీ లేకపోతే 3 years వరకు యాంటీఎపిలెప్టిక్స్ ఆపకూడదు. ఐఎమ్ ద బెస్ట్ ఎగ్జాంపుల్. నేనే నా సీజర్ రాలేదని ఆపేసాను, సీజర్ వచ్చింది 3 సార్లు 5 సార్లు సీజర్ వచ్చింది నాకు. ప్రతిసారి డ్రగ్ డోస్ తగ్గించిన ప్రతిసారి వచ్చింది. నేను ప్రతిసారి చదువుతా ఉండేవాడిని, ఆపకూడదు కానీ ట్రై చేద్దాం, ఎందుకో చదువు ఎగ్జామ్ వస్తుంది కదా, ఐక్యూ తగ్గిపోతుంది కానీ ట్రై డోస్ తగ్గించిన ప్రతిసారి సీజర్ వచ్చింది మేడం నాకు. అది ఎందుకని నేను చెప్తున్నాను.
అంటే 2-3 మీద ఉన్నారా, లేకపోతే సింగిల్ ఎపిలెప్టిక్ అది కూడా స్టాప్ చేశారా?
సింగిలే మేడం, డోస్ తగ్గించేవాడిని నేను.
ఓకే ఓకే.
అంటే దాన్ని అంటారు కదా మేడం, ఓవర్ ఎంతూసియాస్టిక్, కొద్దిగా అతి తెలివి తదిస్తా దానివల్ల మేడం. సో ఐ నో దట్. సో ఐ లాస్ట్ 1 year నుండి అయితే మాత్రం మార్చలేదు మేడం. సో ఐఎమ్ ఆల్మోస్ట్ 8-9 months నుండి ఆల్మోస్ట్. బట్ మధ్యలో ఐ డోంట్ నో, మేబీ యాంటీబయాటిక్ ఓవర్ డోస్ కాదు, ఆల్సో కాదు, డ్రౌజీనెస్, కొద్ది ఇరిటేషన్ అది ఉంటా ఉంటుంది. బట్ ఐ కెనాట్ సే. బట్ ఓవరాల్ అన్కాన్షియస్నెస్ సీజర్ అయితే రాలేదు లాస్ట్ 9 months నుండి. మధ్యలో ఆరో అయితే వస్తూ ఉంటాయి మేడం. బట్ ఐ కెనాట్ ఎక్స్ప్లెయిన్ సడన్ గా ఇది సీజన్ అని నేను చెప్పలేను ఆరో వచ్చినప్పుడు. కానీ మేబీ నేనైతే డౌట్ వచ్చినప్పుడు వల్ల టాబ్లెట్ వేసేసుకుంటాను ఏమైనా డౌట్ వస్తే.
గుడ్, థ్యాంక్ యూ సురేంద్ర.
థ్యాంక్ యూ.